Welcome to our lecture on shock, understanding shock, and hospital code blue. Our outline consists of defining shock, the classification of shock, understanding the progression of shock, collaborative care, and hospital code blue. So what is shock? Well, it's a syndrome characterized by decreased tissue perfusion and impaired cellular metabolism. So basically, it's an imbalance in the supply and demand for oxygen and nutrients. Shock is a life-threatening condition and it has a variety of causes. It's a common occurrence in the acute care setting. Some definitions of shock define it as a mean arterial blood pressure inadequate to meet the needs of the tissues. It's characterized by the inability of the circulatory system to supply adequate oxygen and nutrients to the tissues, either because of 1, an ineffective cardiac pump, 2, ineffective circulatory system, or 3, inadequate blood volume, and all lead to the inability of the circulatory system to supply adequate oxygen and nutrients to tissues. So basically, the demand for oxygen is not met by oxygen delivery. What are the consequences of reduced oxygen supply? Well, you have cellular oxygen deprivation, which leads to tissue deprivation, which leads to organ oxygen deprivation. You have changes to the cell membranes that causes fluid shifts. The sodium-potassium pump fails, which is very important for homeostasis regulation. If vital organs don't receive oxygen, they will shut down, and more than 3 vital organs shutting down is a very high mortality. So there are different types of shock. Hypovolemic shock can be one of 2 types. It can be absolute hypovolemia, so looking at loss of whole blood through hemorrhaging, plasma, loss of other bodily fluids such as through vomiting and diarrhea, diabetes insipidus, diuresis. And it also can be relative hypovolemia, which is the pooling of blood or fluid, as in ascites or a bowel obstruction, internal bleeding, maybe from a fracture or a ruptured spleen, or massive vasodilation, as in sepsis, where the fluid volume moves out of the vascular space into the extravascular space, and this is known as third spacing. So relative hypovolemia is related to third spacing. Neurogenic shock are the hemodynamic consequences of injuries, disease, or both to the spinal cord at or above T5. It can also result from spinal anesthesia and vasomotor center depression. Septic shock is from an infection. Typically, a gram-negative infection is the most common, but you do have others through gram-positive bacteria, viruses, fungi, and parasites. And then anaphylactic shock is from many different types through contrast medium, blood products, insect bites, drugs, foods, vaccines, latex, environmental agents, and anesthetic agents. This diagram shows the progression to 2 other syndromes: systemic inflammatory response syndrome, or SIRS, and multiple organ dysfunction syndrome, which is MODS. So as you can see at the top, you have the different types of shock, and if you can't get those under control, it can lead to SIRS. And SIRS is basically the inflammatory response to shock, and it can be triggered by both infectious and non-infectious conditions. So such things as ischemia, inflammation, trauma, infection, or a combination of several insults. And so it's not always related to infection. And if that does not get under control, it can lead to multi-organ dysfunction syndrome. And that's the failure of more than one organ in an acutely ill client in which homeostasis cannot be maintained without intervention. And when 3 or more organs come into play in MODS, it's about a 70% mortality rate. Shock has four stages: initial, compensatory, progressive, and decompensated or irreversible. So let's talk about the first stage of shock, which is the initial stage. And in the initial stage, everything's happening at the cellular level. So there's no outward clinical signs that there's any problem. But what's happening at the cellular level is that the metabolism is starting to change because of a lack of oxygen. So you have metabolism changing from from aerobic to anaerobic because of the lack of oxygen. And that causes a lactic acid buildup. So when oxygen levels are low, carbohydrates break down for energy and they make lactic acid. And so you have this buildup of lactic acid. Now, lactic acid is a waste product and must be removed by the liver, but this process requires oxygen, which is unavailable because of the decrease in tissue perfusion. And then this stage is followed by the other three clinically apparent but overlapping stages of shock, which are the compensatory, progressive, and the decompensated or irreversible. So at this stage, it's the beginning signs of not enough oxygenated blood. So moving on to the compensatory stage, it's specific to each type of shock, and the priority is to treat the underlying disorder, and it relies upon the mechanisms of homeostasis. So what's happening in the compensatory stage is the body activates as many of the compensatory systems as possible to try and protect the body from the consequences of anaerobic metabolism, to try and maintain the blood pressure and volume within the normal limits. And the goal is to maintain homeostasis. And so there's an array of compensatory mechanisms from neuro, biochemical, and hormonal compensatory mechanisms. And for in this stage, it's very important to treat that underlying cause, as I've already said. So let's talk about what happens in the compensatory or the compensated shock. So one of the first clinical signs of shock is hypotension. And that is again because of a decrease in cardiac output and a narrowing of the pulse pressure. And so as a result, you'll have tachycardia, you'll have a weak pulse, you'll have cool peripheries and a delayed cap refill because blood is being diverted away from the periphery and non-vital organs such as the skin, the lungs, the kidneys, the GI tract. And you have decreased urine and it could be concentrated because again, the blood is being diverted away from the kidneys, and also the kidneys feel that they need to hold on to fluid, and so they'll reabsorb sodium and water, so the urine will be concentrated. And so I think I've covered most of the corresponding causes here. So the release of the catecholamines because of the sympathetic nervous system comes into play, which releases catecholamines, which causes that systemic vasoconstriction. So you'll have that cool, clammy skin and a reduced stroke volume. So trying to really get the blood to stay within the heart, not make the heart pump any harder than it needs to, and to supply the blood to the brain. You could have an increased respiratory rate, again, because of the shunting away of blood from the lungs. And so there's that increasing of dead space in the lungs where there's areas in the alveoli which would be taking place in gas exchange that's not taking place because there isn't that blood for it to take place. So you have a VQ mismatch, so a ventilation perfusion mismatch, and so that will cause an increase in the rate and depth of respirations. Nausea because of the blood being diverted away from the GI system, so it could cause impaired GI motility, so you might get nausea. Increased blood sugar because of that stress response, so the body's producing more sugar because it's under stress. Confusion and anxiety, again, just from the shunting of blood, which is trying to get to the brain, but maybe enough is not getting there. And so you have that confusion and anxiety happening. And so there's a lot going on here. And it's really these compensatory attempts are trying to overcome the consequences of anaerobic metabolism. And it's really trying to maintain homeostasis. And so If the perfusion deficit is corrected, the client recovers and with no really residual sequelae, so no residual concerns. But if the deficit is not corrected, then the client enters into the progressive stage. So the progressive stage begins when compensatory mechanisms fail, and aggressive interventions are needed at this stage to prevent multiple organ dysfunction syndrome, or MODS. And so the first system to display critical dysfunction at this stage is the respiratory system. So you have decreased blood flow and sympathetic nervous system stimulation. The pulmonary arterioles constrict, resulting in decreased blood flow to capillaries, and you have a ventilation perfusion mismatch. The other thing that's happening is, because of what's happening at the cellular level, there's capillary leakage, which means that there's movement of fluid into the interstitial space, and you get alveolar edema. So the patient develops tachycardia, crackles, and there's increased work of breathing. All along, cardiac output is falling, the blood pressure is falling, and perfusion to the organized becomes even more compromised, and organ failure begins. So you may have the patient starting to complain of chest pain. They're going to have significant hypotension. They may have arrhythmias. Again, you have hyperperfusion to the kidneys. So that's going to start to lead into some of the renal failure that you'll see. You may have oliguria, it means that there's no urine output. If you look at your renal labs, you could have an increase in creatinine. And metabolic acidosis results from that inability to excrete acids and not able to reabsorb bicarbonate. Other things that are happening, the GI system could develop ischemia, and that could lead to ulcers, a GI bleed. The liver is failing to metabolize drugs, and it's having a hard time getting rid of waste products such as lactate. And with the failure of one organ, this accelerates the failure of other organs. And this is where you get into this multi-system failure. And again, aggressive intervention is required at this stage. So in the refractory or irreversible stage, this is profound hypotension and hypoxia. There's failure of the liver, the lungs, and the kidneys, and that results in accumulation of waste products, so such as lactate, carbon dioxide, urea. And again, as I said before, the failure of one organ leads to the failure of several organs, and the compensatory mechanisms are overwhelmed. And at this stage, you have respiratory and cardiac arrest are inevitable. So let's move on to the different types of shock. So hypovolemic shock is a loss of intravascular fluid volume. And so there's a reduction in circulating volume. And there's typically three types of problems. Fluid can move out of blood vessels and into the body spaces. That's one. Fluid moves into the interstitial spaces, such as in burns or allergic reactions, sepsis. Or there's loss of fluid from the body, such as blood or plasma loss, loss through diarrhea, vomiting, excessive diuresis. And the symptoms generally do not appear until there's a loss of about 1/5 in the adult or 1/3 volume in the infant child's circulating volume, which is approximately 750 mils for an adult. And so what happens is you have the causes, and the body goes into self-preservation. So they go through that compensatory stage to maintain the homeostatic mechanisms. And they go into a survival mechanism where they increase the heart rate and systemic vasoconstriction. So very similar to the stages that I've already talked about. But one of the system that comes into play is the kidneys. And when you have a decrease in blood volume to the kidneys, it activates the renin-angiotensin system, which is the RAS system. And it also releases ADH, as you recall from before. And so what that system does is it increases sodium and vasoconstriction, and it increases the water preservation. And so that's one of the systems that comes into play. So this is the pathophysiology in hypovolemia. So you have a decreased circulating volume, means there's a decreased venous return to the heart, means a decreased stroke volume, decreased cardiac output, decreased cellular oxygen supply, decreased tissue perfusion, and impaired cellular metabolism. And so as the stages of shock, as we've already discussed, you have an increase in the heart rate. A systemic vasoconstriction is triggered because of an increase in the sympathetic activity and release of catecholamines. There's compensation by the kidneys, so reduced blood flow results in the release of renin because of that activation of the renin-angiotensin system. And so what happens there is you have the holding on to sodium and vasoconstriction, and then ADH is released from the posterior pituitary, which causes an increase in sodium reabsorption and holding on to water, which is trying to increase the blood volume, which is trying to increase the blood pressure. So let's look at the clinical manifestations. The normal response to fluid loss is dependent on really a number of factors. So the extent of injury, the age of the person, their general health state. But typically, a healthy individual can compensate for a sudden loss of up to 15% of their total blood volume. The BP can be in normal range with up to 750 ml loss in some clients. It cannot be the only sign when determining fluid loss, so this drop in blood pressure. Other things to look for is the skin color may be pallor or pale and clammy, because remember, blood is being diverted away from those non-vital organs, and one of them being the skin. And so you'll also see delayed capillary refill. Heart rate will increase, urine output will diminish, and the patient may be nauseated as blood moves away from the GI tract. So you may have absent bowel sounds. There will be an increase in respiratory rate as the body attempts to blow off excess acid. Remember the lactic acid production, resulting in respiratory alkalosis. And you may have altered level of consciousness from confusion to aggression to stupor. So what is the collaborative treatment here? Well, you want to start off by optimizing oxygenation. So you're going to give oxygen, but remember that's dependent on the cardiac output and the available hemoglobin. And so if the patient has lost actual blood, you may actually need to give a blood transfusion to actually be able to optimize the oxygen. So what you're trying to do is increase the supply and decrease the demand. For cardiac output, you may optimize the cardiac output with drug therapy or fluid replacement. Hemoglobin, if you've lost hemoglobin, you'll need to give a blood transfusion of packed red blood cells. You may be required to mechanically ventilate the patient if supplemental oxygen is not enough. You'll need to ensure that you have an IV ready. So it's typically you'll be giving fluids quite rapidly. So rapid IV infusion. So you need to ensure that what is inserted is probably 2 large IVs, or a central line may be required. And remember, these patients are in the intensive care unit. Strict in and output is very important. So you're going to need a Foley catheter. And then thinking about fluid replacement or volume replacement, what are you going to be giving that patient? And it really depends on the extent of the loss. And so you may be given such thing as Ringer's lactate or normal saline, or you may be giving something much more than that, such things as a colloid, which is albumin. And it's good for really pulling the fluid back into the intravascular space. And so it really depends on the volume replacement that's required. But treatment is really always focused on the ABCs and determining that underlying cause. And sometimes the blood pressure remains low despite fluid volume replacement. And that's where you may need to give a vasoconstrictor or other cardiac meds. And so vasoconstrictors such as adrenaline or noradrenaline or dopamine, they act on the alpha and the beta receptors in the peripheral blood vessels, causing them to constrict and causing the blood to be shunted back to the heart to increase the blood pressure and the cardiac output. So I'm going to stop here and we'll move on to cardiogenic shock in our next lecture part.